I will briefly describe about the role of interventional radiology in the head and neck. First of all, what is interventional radiology? It is defined by a Society of IR as a delivery of minimally invasive, targeted treatments performed using imaging for the guidance. Sorry? Interventions in the head and neck can be performed via percutaneous, endovascular, or combination of these approaches. The procedures that predominantly require percutaneous access include biopsies and aspirations, sclerotherapy, radiofrequency ablation, and the cryoablations. The transarterial or the endovascular approach is a mainstay of treatment in the head and neck bleeding as well as in the pre-surgical embolization of the tumors. Sometimes the combination of percutaneous and the endovascular approach, such as in the high vascular malformations and the hypervascular tumors. Now the image-guided biopsy, it plays an important part in the diagnosis and management of deep-seated head and neck lesions. As the superficial lesions and the palpable lesions, biopsies in these cases can be done by the ENT surgeons or the maxillofacial surgeons. But in case of deep-seated head and neck lesion, image-guided, that is CT-guided biopsy is important. With the knowledge of cross-sectional anatomy, to see the anatomical structures in the path of the needle, it is very much important to know the cross-sectional anatomy. Percutaneous aspiration and the biopsy technique have a very high yield of diagnostic sample approaching 90% with a very few reported complications. These are few CT-guided biopsies of deep-seated lesions. And this is a case of parapharyngeal mass in which the image-guided biopsy was done by the yes, sir. In which the image by the paramaxillary approach, look at the deep-seated lesion and the biopsy was done. In this case, the mass was in the masticator space and the biopsy was done by the subzygomatic or the intercondylar approach. It is a deep-seated lesion and difficult for surgeon to do the biopsy blindly. Image guided, that we can do also the ultrasound guided biopsies, and usually the CT guided biopsy is done on the plain CT scan, but sometimes if you are suspecting that vessel is in the path of the needle, we give contrast before doing the biopsy. In this case, the mass was in the epidural region here, and adjacent to it was the vertebral artery. So we give the contrast and have done the biopsy safely. Other procedure that is done percutaneous with the percutaneous approach is the radiofrequency ablation and the cryoablation. It represents focal tumor ablation strategies most often used for the palliative treatment of unresectable malignancies or the resectable lesions. Advantages of RFA and the cryoablations are the absence of surgical scar, reduced recovery time, and the most important is the ability to visualize the treated tumor both during and after procedure to determine treatment success in patients with poor surgical risk. There are three major complications, all related to the proximity of electrode to the carotid artery. These are stroke, carotid blowout leading to death, and the threatened carotid blowout with subsequent stroke. So the tumors surrounding the carotid artery are immediately adjacent to the carotid artery, should not be treated with the RFA or the cryoablation. This is a case of a large unresectable tumor of hypopharynx involving the hide bone as well as subventral region, in which the radiofrequency ablation was done. This is the 3D reconstruction showing the RFA electrodes seen in the submental region, also crossing the hide bone. So the cryoablation was done in this case for the palliative purpose, as the tumor was unresectable. Another important is the sclerotherapy, which is also done through the percutaneous route. The procedures we do, and the indications for these sclerotherapy are the low flow AVMs, plunging granulas, shallow seals, other benign cysts of head and neck. We do sclerotherapy in these cases. In the low flow vascular malformation, it includes usually the venous and lymphatic malformations, and constitute most common indication for the sclerotherapy of the head and neck. Most commonly used sclerosing agents, we use ethanol, sodium tetradecyl sulfate, and the bleomycins. 95% good results with the ethanol, and also good result with the sodium tetradecyl sulfate, and the poor outcome have been reported with the diffuse vascular malformations. This is a case of slow flow vascular malformation which was already diagnosed and surgery was done. Here it is a scar, but there is a residual or recurrence, and ultrasound was done which shows the slow flow vascular malformation, and the ultrasound guided needle was placed in this region, and the contrast was given. We have seen on the fluoroscopy there is no early washout to suggest the high vascular malformation, and the sodium tetradecyl sulfate was given in this case. This is the follow-up. There is no swelling, and ultrasound was also done in this case. There was no residual. So this is the result of sodium tetradecyl sulfate in the low flow vascular malformation. Our main focus is the endovascular management in the head and neck, and that can be divided into the three main categories: management of acute hemorrhage, management of vascular lesions, and the venous sampling. In acute hemorrhage, epistaxis and the carotid blowout. Management of vascular lesions, that are the tumors, we usually do the pre-surgical embolization of the tumors, and there is the arterio-venous malformation. Before proceeding toward the management of epistaxis, one must know the simple anatomy, vascular anatomy of the nasopharynx in the nasal cavity. It is supplied by the internal maxillary artery, then continues as a sphenopalatine artery. Here it is a greater palatine artery, and the superior labial branch of the facial artery. The important is the anterior and both posterior ethmoidal arteries from ophthalmic artery. These are very dangerous for embolization. It may lead to their blindness. So, epistaxis can be anterior or the posterior. Anterior epistaxis, you will deal with simple techniques, that is the cautery and the nasal packing, and the posterior epistaxis, we can use the posterior nasal packing, and options for ligations are available for posterior epistaxis by endoscopic or by neck exploration or the specific incision. But the selective embolization of bleeding vessels with particles or the coil is increasingly used treatment for such cases of refractory epistaxis, and has been shown by many to be safe and effective. These are causes, everyone is well aware about the causes of epistaxis. So we do the embolization by selectively cannulating the external carotid arteries. So we start procedure with the puncture of the common femoral artery and place the sheath. This is the sheath we place in the common femoral artery, and with the help of guide wire and catheters, we place the catheter in the common carotid artery. Then into the external carotid artery and selectively cannulate the branches of external carotid artery. This is a case of epistaxis in which the facial artery was selectively cannulated and the bleeding point was identified, which was embolized. This is a post-embolization run showing the complete embolization of bleeding point and preservation of the normal vessels. Carotid blowout. Carotid blowout is defined as bleeding from carotid artery or its branches. Carotid blowout is a well-known and much feared complication of advanced head and neck malignancies, whether treated surgically or with radiotherapy. Surgical intervention for such patients is technically difficult and is often impossible to identify the exact source of bleeding due to tumor bulk, ongoing infection or soft tissue fibrosis following prior surgery or the radiotherapy. So, endovascular treatment, that is endovascular treatment is now considered by some to be gold standard for this group of patients. There are three main options available for the endovascular treatments, that is permanent balloon occlusions, selective embolization, and the placement of an endovascular stent. Permanent balloon occlusion, it prevents the blood flow to the bleeding vessels, but it occludes the main trunk. Before placing the permanent balloon occlusion, temporary balloon occlusion test should be done to predict the risk of cerebral ischemia. Other is selective embolization, using a variety of material to occlude the bleeding vessels, leaving the main carotid trunk intact. And the placement of endovascular stent, which allows continued cerebral blood flow. So this is a case of carotid blowout due to malignancy, in which the temporary balloon occlusion test was performed, which shows there is no risk of cerebral ischemia. After that, the coil was placed, but still there was bleeding, and we have placed the permanent balloon occlusion. Now the management of vascular lesions, that is the pre-surgical embolization of the tumors, which is usually done in the glomus tumors, angiofibromas and meningiomas. The aim is to devascularize the tumor prior to surgical excision. It may be done in cases in which the patient is unfit for the surgery or unfit for anesthesia. It can tend to shorten operative time by reducing blood loss and reducing the period of recovery. For this reason, it is now a well accepted part of treatment of juvenile nasal angiofibroma. Embolic agent in common use are polyvinyl alcohol, embospheres, liquid embolic agent, gel foam and coils. I have done many cases of pre-surgical embolization in the trauma center. These are few of them. Here the internal maxillary artery for selectively cannulated large blush was identified. This is the AP view of the same patient showing a large blush. This is after embolization run of internal maxillary artery, blush has gone. So these are check angiogram of external carotid artery showing no blush from branch of external carotid artery. Again, the contralateral check, the no blush identified from the contralateral external carotid artery. The important here is to check in every patient the internal carotid artery to see the blood supply from the ophthalmic artery, which is very dangerous to embolize. Another case of pre-surgical embolization, large blush was embolized, no blush identified. Check angiogram of external carotid artery showing here we see the blood supply from the branch of the facial artery, which was here we selectively cannulated the branch of facial artery, the blush was identified and embolization done, there no blush. Here the contralateral internal maxillary artery was also cannulated, which showing the supply of the tumor. After embolization, no blush. So completely embolized, in this case bilateral internal maxillary artery and the branch of facial artery. Another case of perisurgical embolization, there are large blush from the internal maxillary artery. Here we embolize, no blush. Again the check angiogram showing no blush from the other branch of external carotid. Contralateral external will also show no blush. This again another case of perisurgical embolization. Same AP view. After embolization, so check angiogram should be done after embolization to see the collaterals from other branches of external carotid artery. Again, this is blush. This is the static image of the angiofibroma showing a large blush. And this is after embolization, no blush identified. Other tumors which require perisurgical embolization are the paragangliomas, the glomus tympanicum, glomus jugulare, and the carotid body tumors. Although surgery remains the mainstay of treatment, the perioperative embolization has led to the improved resectability and reduced morbidity. This is very important case, interesting case. This is the 3D reconstruction showing a bilateral carotid body tumors and two other small glomus tumors. The angiogram was done which shows the large blush displaying the external carotid as well, external carotid and internal carotids. And the selective cannulation was done and embolization. This is after embolization run, but it still show the small blush which is supplied by the small branch which was difficult to cannulate, and so the percutaneous puncture was made in this carotid body tumor, and the contrast was given, it show a large blush. So embolization was done percutaneously as well in this case. This is after percutaneous as well as endovascular embolization showing no blush. Then this is after surgery, almost completely thrombosed tumor. So this is the role of perisurgical embolization in case of paragangliomas. This is the case which I have done in the trauma center. Large blush was seen at the bifurcation of internal and external carotids. Selective cannulation was done and embolization done. This is another branch selectively cannulated and embolized. This is check angiogram. Check angiogram shows the blush almost has gone, and surgery was done, there was no bleeding, minimal bleeding, no transfusion required. Now the embolization of cervicofacial high flow vascular malformations. Angiographically consists of nidus or direct communication between the arteries and the veins, that is the fistula. Multidisciplinary team approach is required for the assessment of high vascular malformations. Although smaller lesions can be treated by endovascular embolization alone, but larger and complex lesions needs additional surgical resections. Embolic agent used in the high vascular malformation are the ethanol, glue, or the onyx. Sometimes direct puncture embolization is used to access the nidus of vascular malformation or the draining vein. Direct puncture embolization of AVM is technically easier compared to the transarterial embolization. This is a case of arterio-venous malformation supplied by the superficial temporal artery, which was selectively cannulated and the glue was placed. This is the after embolization run showing no residual arterio-venous malformation. Now the arterio-venous fistulas. They can be congenital, spontaneous, or traumatic. The principle of treatment is preservation of normal vasculature where possible, while ensuring that both distal and proximal vessels of fistula are occluded. Treatment options available for arterio-venous fistulas are embolization with detachable coils, embolization with particles, and exclusion using both arterial and venous approaches, and replacement of endovascular stent. Proper planning of treatment is the key to success, and again requires close cooperation between the interventional radiologist and the head and neck surgeon. This is a case of carotid cavernous fistula in which internal carotid angiogram was done and is also specifying the cavernous sinus and superior ophthalmic vein. The stent was placed in this case, CT scan showing the stent, and after stent placement there was no opacification of cavernous sinus and superior ophthalmic vein. Complication of IR. They are the immediate and the late complication. Immediate can be hematomas at the puncture site, embolic or ischemic neurologic deficit, and sometimes the arterial rupture or the contrast allergies. Late complications are ischemias, pain, skin necrosis, or paresthesia. And sometimes the infections, mostly the vein infection around the stent, it is very dangerous. So take home message is the collaboration of multidisciplinary teams, ENT surgeons, maxillofacial surgeons, neurosurgeons, radiologists, and the intervention radiologists for the better management of the patient. Thank you.